All right, Carrie, I'm going to kick things off. So welcome, everybody. Today's webinar is titled Helping Hospitals Comply with Pricing Transparency Regulations, Hospital Price Index. My name is Tori. I'm the Marketing Director here at Vitalware, and I will be your moderator for today. So thank you for joining. And before we get started, a few quick housekeeping announcements. Everyone is going to be on mute, with the exception of our presenter, of course, but we do encourage you to interact with our speaker using the Q&A panel, which can be found at the bottom of your screen. Please use the Q&A panel for any questions for our presenter and not the chat panel, as we will be monitoring the Q&A panel, and time permitting, we will answer as many questions as we can get to. The presentation is being recorded and will be posted on our site. That link will be shared following the session. So with all that said, I would like to introduce today's speaker, Carrie Martin. Carrie is the founder of Vitalware and the visionary behind our hospital price index solution. He has spoken with many health systems who are working to prepare for 2021 price transparency mandates and has some great insights to share with you all today. So with that, I will pass things over to you, Carrie.
Perfect. Thanks, Tori. Good morning, good afternoon, everyone. So let's jump into this. Time is definitely short. There's a lot of work to do. If you haven't started, I'm going to go through the process, the methodologies that we've come up with, and hopefully give you some insight as to the way that we're helping you protect your data, be transparent for your patients, and hopefully alleviate the data mining that we know is going to take place. To start with, a disclaimer. Again, as Tori said, these are the ideas that we've come up with, the way that we've interpreted the regulations. Your compliance officer, chief legal officer will definitely need to be involved in final calls for the way that you attack price transparency. Vitalware is a mid-revenue cycle software company that focuses on regulatory content for charge masters. We've been #1 in class the last 2 years in a row, and it looks like we're leading this year, so it'll be the 3rd year in a row. The reason that's important is we're using the backbone of our charge master tool to accomplish the transparency requirements. I want to just touch on the lawsuit and where things are at based on our latest and greatest information, go through the actual fact sheet and some definitions, and then just get into our strategy of meeting the mandate, again, providing transparency to the patients, but we've got to protect the data as well. We're putting this out on the internet, and I think it's really, really important that hospital executive teams really think about what this means to future negotiations. And then I want to discuss service package benchmarks, because that's really the biggest lift around what we need to do in the next 45 days or so. So what we know now is there's an appeal that's been filed. It does not look like there's going to be any ruling before the end of the year. So whether or not there's anything that the judge does, it's going to go past when we've got to have this data up and available. The judge did rule on the 24th that the hospitals should disclose this information. I think the biggest challenge is it's hard not to discuss and think it's fair to the patients to be more transparent. So I think that hospitals in general kind of are behind the 8 ball with that defense. I also think that CMS used the fact that you put your charge masters online 2 years ago and didn't have any issues with doing that in a very short time frame. So those are the things that are, I think, just unfortunately becoming hurdles to the judge ruling in favor of the hospitals or the AHA. When we talk to transparency committees and teams, we're really thinking about strategy that protects future payer negotiations and provides transparency to the patients. The second part of that is not easy to do. As we've looked through the data and we look through CPT codes and we try to distinguish between the technical differences and just the, what patients are trying to do and accomplish, it's just a very difficult thing. And I'll get into some of those idiosyncrasies around that, but it's not easy for patients to take a self-guided tour and figure out how to price something that their physician told them needs to be done to them, be it a procedure or whatever. We're talking about 3 different displays. We've got the Charge Master display from 2 years ago, and then there's 2 components with this final rule: all services and shoppable services. Now, all services is all services as long as you have enough volume. We've interpreted some of the volume requirements, and I'll get into that. The shoppable services can be replaced by an estimating tool. So if you provide estimates to patients online, then displaying shoppable services is not a requirement. So in that case, it's one or the other. Effectively, we're displaying a price list with payer allowed amounts. There's no other way to interpret it. The government used all kinds of fancy language around payer negotiated charges, but the only way to interpret what they're talking about is to just call it the payer allowed amounts. It does get down to payer plan. I mentioned already volume, and we'll get into that. Government payers, TRICARE, Campus, any federal programs where there's an existing negotiated rate for all hospitals is off the table. Workman's comp is off the table. Traditional Medicare is off the table. One of the biggest things we found in the data is all of the payers, the onesie twosie payers that may be just an out-of-state patient or whatever. All of that actually has to be cleansed and cleaned up because we're talking about just your contracted payers. Contract modeling could be used. The challenge is modeler tools and trying to predict what the physician is going to use for an implant or whatever, devices, drugs, etc. As we know, physicians tend to change their mind about 25% of the time once the procedure begins. So it's very difficult to model things when you really don't have a good idea of normal physician practices. So we believe 837 and 835 data is the most accurate and streamlined approach. It's not a perfect approach. As you know, 835s can get a little messy. Sometimes payers will lump a big payment on something that makes no sense. So those are the things that we've got to actually get through as we cleanse and go through the data. But 835s to us is the most accurate streamlined approach to gathering the allowed amounts. Benchmarking. Service packages are basically claims data. The one mistake that CMS made 2 years ago is they said, put your charge masters online. What they didn't realize is all the OR codes, the operating room codes, did not exist in charge master data. So this time they've covered that with service packages, and we believe benchmarking service packages is critical for long-term viability for the hospital. Everybody talks about the machine readable file. That does not mean downloadable. We do not want to make this easy for data miners, the government, other payers, and your competitors. So it is not a requirement to be downloadable. It is a requirement to be machine readable. And don't worry, CMS will continue to refine the requirements. Everybody knows this about CMS. If they see something they don't like, they'll just change it. Most CFOs we've talked to have said less is more, and this is a homework assignment. I want to get a C plus. I don't want to get an A plus. So think about that as you're thinking about what should we display, how do we be fair to the patients and somewhat protect our data. So the fact sheet, as you can see right at the top, requirement for making public all standard charges, all items and services in a machine readable format. This is the all services requirement. They want gross charges, payer specific negotiated charges. Again, a term that they made up. De-identified minimums and maximums on your negotiated charges. Discounted cash price. At the bottom, it says CMS believes this information and format is most directly useful for employers, providers, and tool developers. So this component is not for the patient. It's for future transparency tools. In the middle of the screen, they talk about service packages. They want each item or service and service packages. They want any code, for example, IPPS code used by the hospital for accounting or billing purposes. This is where they've covered what was a deficit in the charge master from 2 years ago. So your colonoscopies, your breast biopsies, your total knee codes that don't live in the charge master are covered this time around with service packages. Then we get into the shoppable display. Again, shoppable services can be replaced with an estimating tool. CMS has come up with 70 particular services. The hospital has to come up with another 230. That's a heavy lift for critical access hospitals. So they have given some relief to critical access hospitals. They have, again, used the term utilization or volume. They used it about 30 times in the final regulation. So this should be based on where you have enough volume to feel good about displaying those shoppable services. And many critical access hospitals may not be able to get to 300. If you don't do some of the 70, CMS was very specific that you need to say that you don't provide that service at your hospital. So of those 70, if you don't do them, there's definitely an indicator that needs to be put against those shoppable services. They want it to be plain language descriptions. They want it to be based on utilization. They want you to update it at least once a year. It needs to be on a public web page, and you can't ask the patient for any information regarding birth dates or those types of things that are specific to the patient. No passwords, no registration. So when we look at the data necessary to be able to accomplish what we call the HPI data set, is we need claims data, we need remittance data for the allowed amounts, we need the CDM with revenue and usage for the individual items and services, and potentially fee schedules. Although what we've learned is with the contracted payers, most of the time the 835s will come within a few cents to a few dollars of your fee schedule items. So we're really learning through all the 6 million claims we've gone through that fee schedules isn't as necessary because the contracted payers do tend to follow their own published fee schedules. So let's level set on some key terms. So they said gross charge. So for us, gross charge is either the CDM price or the total claim charge. Payer specific negotiated charges, again, we can't define that any other way but negotiated allowed amounts. Discounted cash price is a price that you give to patients purely because they're paying cash, writing a check, put it on their credit card. It's not anything to do with poverty levels or the discounts you give to patients that fall into those categories. De-identified minimum and maximum, again, your best paying payer and your worst paying payer across all the services and service packages. We've defined service package to mean single instance claims. We do not want the claim where the guy was putting up Christmas lights, fell off the ladder, broke an arm, twisted a knee, and bonked his head. There's too many things going on that claim to separate out the supplies, the drugs, the CT scan, is it of the head or the knee, etc. So we're really trying to boil down to the plain vanilla procedures that you would feel good about in a service package, like a cardiac cath, a colonoscopy, a total knee replacement, or a breast biopsy. Again, single instance. Machine readable, we use the JSON format for our machine readable. And I'll get into a couple of ways that you can choose to display that information, but it does not mean downloadable. Please do not make a clickable spot that can just download the whole all services file. We know there's a penalty, $300 per day, which is fairly steep. However, there's other things that Medicare has followed up with. They're going to give a written notice first, so a written warning. Then they're going to create a corrective action plan, which sounds like an integrity agreement to me. And then they have threatened the potential of publishing on a website hospitals that fail to comply. So a lot of other things to consider that probably are more detrimental from a PR perspective than just the $300 per day. So this is our second version. Our first version was helping hospitals with the 1.0 version from 2 years ago. So we are talking about 3 different displays. We're talking about a charge master display. We don't believe anything changed from that display. We're not adding anything to it. We are still genericizing the descriptions. It's important to genericize CPT descriptions because they're not patient friendly and they are Google friendly. If you take one of your charge master descriptions with a drug name and a dosage and a route of administration, you will definitely hit drugstore.com and it will show you wholesale prices for those drugs. We did not think 2 years ago that was good for our hospitals, so we genericized the descriptions. We took out trademark names. We took out drug names. We took out dosages. We took out routes of administration. We made it plain Jane descriptions, which we felt were more patient friendly, and definitely took the Google friendliness out of those descriptions. With the all services, we're going to utilize your claims data to determine high and lows and average gross charge for all service packages. We're going to bundle the drugs, the supplies, the anesthesia, the recovery, the devices. That all goes into those services, those service packages as CMS has defined. We're going to utilize the CDM revenue and usage to determine the individual items that will be placed on the all services tab. So your x-rays, your CTs of the head, those would qualify as individual items or services. And we're using the volume of 11, and I'll get into why we do that. We will assist you with helping you with your shoppable services if you're not using an estimating tool. We will do all the data munging for you with the 835s to pull out the de-identified mins and maxes. We are using standard deviations to throw out. We ran into one the other day where somebody gave us $12,000 for a blood draw. There was a lot of other things that happened on that claim, like chemotherapy drugs and chemotherapy administration, but for some reason the payer put $12,000 on the blood draw code. Obviously, we need to run through the data and get that level set and throw those types of claims out. We provide a back-end administration. Our CDM tool is the back-end administration tool. Every bit of data is in your control. Whatever data gets displayed, whatever disclaimers you have, the line items that show, the line items that don't show, completely controlled by you. We're going to populate that administration system, but you're in control of everything that gets published. I do say this regularly now on our implementation phone calls. This is an iterative process. You only want to publish the data that you feel good about. So if you've gone through the data, you find claims data, you find payers, you find your major payers, you feel good about data, publish that. Anything you don't feel good about, it's an iterative process. If it takes you through the month of January to get everything loaded and online, I believe that's fine, because nobody's going to ask you to put data on the internet that you don't feel good about or that you don't think is right. The last thing I said, service package benchmarks. You need to look at your two competitors, your two closest competitors, and see what are they charging for total knees or breast biopsies or colonoscopies. And we've built these service packages. We have over 3,500 service packages that we've built. We're using Medicare claims data to provide you with competitive intelligence, again, behind the scenes, so that you can start looking at, will you be competitive when patients start shopping for services? This is some of the inpatient shoppable list. The thing that you'll notice right away is the 470 is the same across your inpatients, but it means hips, joints, and knees. We have seen data where hip replacements versus knees versus ankles actually look pretty significantly different from a gross charge perspective. It may not affect reimbursement, but it may affect your patient choosing your hospital or the hospital down the street. We think there's too much data in those 3 different joint replacements to put it all on one line. That's how CMS has told us to do it, but we believe that we need to break some of those things out. We have found that the knee is typically more expensive than the hip, and the ankle is actually the most expensive joint replacement in all the data we've looked at. With the outpatient list, so CMS again gave us some codes. So 43239 is one of the codes that they gave us, which is a biopsy of the esophagus, stomach, or small intestine. That is our patient-friendly description that we think that the physician would say to the patient, and the patient understands those words. If you look off to the right, you will see 9 other codes that are in that same family of codes that have technical differences. We cannot expect patients to wade through those 9 codes and figure out which one the physician is going to perform. So our view of the world is to create patient-friendly families, bundle the codes together, bring the claims data together so that we don't have volume issues. And that's how we're approaching this from the standpoint of being patient-friendly and somewhat camouflaging the data to all the payers. You'll see sometimes we use commas, sometimes we use dashes. Anytime we use a dash, like CMS does in a lot of their publications, we believe that again camouflages the data. You can't necessarily look for any given CPT code and get to the data in the way that we're displaying it. So that makes it hard on data miners. We also are bringing all that claims data together because it makes sense to us from a family perspective. There's not a lot of differences from one code to the next when we select them in a family, but it definitely, again, creates some camouflage and alleviates some of our volume issues when we have a particular payer and we've only got 1 or 2 claims that were one of those 9 different codes that are out there. So again, those are the ways that we've interpreted the rules. What we're trying to do is, again, be fair to the patient, but also camouflage the data and bring the data together so that we don't run into big volume issues when we get to our smaller payers. We are producing white labeled patient education information that you can use, put on your website. If we're going to have a smarter healthcare consumer, it's going to come with education. That education information needs to say Dr. Smith and Dr. Jones are both orthopedic docs. They practice somewhat differently with regards to what implants they use, how long they take in the operating room to do that total knee, etc. And that's some of the things that we're publishing in our patient education information. This is our ChargeMaster display, the 1.0 version of our product. There is a place for a logo. There's a place to search. It shows your hospital name. We give you a link that you put on your website that takes you out to this information. You will also see a shoppable items and an all service items. Again, we genericize the descriptions on the ChargeMaster display. When we get to our shoppable items, we have our billing codes as required, our DRG codes if this was inpatient. We have our gross charge amount, our low and high price. Low and high price are not required fields. We believe it's good patient education to show that those low and high prices for those different codes. The patient does have to select their payer plan, and the patient now does have to do a search. So if they search for biopsy, select one of the biopsy families of codes, then they will see the minimum, maximum, de-identifieds, and the payer that they selected. So that's our display. Again, you can't search for codes that are in ranges. We have brought those families of codes together, and we're using very patient-friendly descriptions in our displays. When we get to the all services display, we don't believe it changes anything. There have been many of our clients that have said, well, wait, they said machine readable. Well, this format is machine readable. If I take this and highlight all those columns and rows of data, paste it in Excel, it will paste perfectly. That qualifies as machine readable. However, some of our hospitals have said, no, I really want machine readable. And these are the formats for machine readable. And this is just an example of where we bring all the data together. You still have to pick pay or plan. You still can do a search, but it is paginated through 25 rows at a time. And it's not something that's human readable. And we put that right at the top as a disclaimer: all services display in machine readable format, not intended for patient use. So let me talk about our service packages. So when we saw this last November in the final rule and the fact sheet, we said, well, what is a service package? Well, we've defined it as a claim, a pretty plain Jane claim. In this case, we're displaying a total knee. You will see some unclassified drugs in the 250 revenue code, some unclassified supplies in 270 or 272. You'll have your recovery, your joint device, your bone screws. You'll get down to your knee x-rays, your blood draw, your CBC, your fentanyl to make the patient go to sleep. And finally, that principal code that drove this service package, which is the joint replacement procedure. All of those add up to $49,000. If this was the highest claim we found, that would sit in the high column. If our low claim was $28,000, that would sit in the low column. And then maybe our average is closer to $38,000 across the board. So that's how we're developing those first three columns of data: the average charge, the low, and the high. Again, low and high are not required, but we do believe that's super good patient education information. The typical that we're finding is about a 75% threshold. We see these codes together on the same claim about 75% of the time. We can change that threshold if we're getting other codes that don't have anything to do with this claim. We can raise that threshold or lower it if we're not getting the standard things we see across all the ways that your physicians practice. Then we load all of the data. So we've taken all the data from you, we've brought it together, and we load it into our backend tool. We have the Shoppable Publish button. We have the HPI Publish, Service Publish button. So each of those are published out to the website independently. We can look at our SAF price list. We can look at our competitors' prices for these service packages. But you can see this is our numbering system. O is outpatient. Our primary or principal code 44389. Our other codes under billing codes that fall into that category or family. You can see our shoppable services column. The ones say published, the zeros don't publish. The not performed is how we identify those 70 or some of those 70 that we don't do at our hospital. And then the all services display. We have our average charge, our discounted cash price, our gross charge low and high, and then all of our payers and our de-identifieds are off to the right. Our ChargeMaster tool doesn't have a column limit, so if you have 50 major payers that you have contracts with, or 70 or 100, really easy for us to add more and more columns based on the number of payer plans that you have contracts with. We also now have loaded this data and we need to do some litmus tests. So one of those litmus tests is to lay the CDM price down to the average gross charge from the claims data and make sure that we are looking at the CDM price and that the CDM price for our combined families holds water as compared to how it's going out on claims. So that's one of the litmus tests we perform for the single items. Then we go into the packages. So again, I said the 1 means publish, the 0 means don't publish. So our recommendation is for this very first line item, drainage of a breast cyst using a needle, the CPT code 19,000, it is in a package. It says publish the first line item, do not publish the component codes. So the drugs, the supplies, the ultrasound guidance would not be things that we publish. However, you could, if you want to. CMS gave us some examples, but they did not say we had to publish all the components. Again, patients get confused easy, and to show those different things may just cause more questions for the patient. So we've decided to recommend publishing the main code, having the component codes right underneath it so you can see how that package has been built, and then what the individual gross charges are on an average basis, etc. Minimums, maximums, Aetna, Alliance, Cigna, Humana, Blue Cross, etc. You will see clear off to the right. And then we'll have our de-identified min and maxes as well. So that's our service packages on the left-hand side. We have a volume number. Again, we're recommending anything greater than 10. We don't believe the law of averages on these service packages are good as onesie-twosies. You can't feel good if you only have one claim for one payer with one set of allowed amounts, especially if that payer or that patient went way south during the procedure. So we just believe that the volume number is something that your hospital executives should think about and stick a stake in the ground. The reason we use 10, CMS themselves, when they sell data to us, when we buy the MedPAR SAF data, we are not allowed to display any data for any claim, for any patient, for any hospital that is under a volume of 10. So that's why we're recommending greater than 10, because it's CMS's own rules in their own claims data. Service package benchmarks. So I've mentioned this a couple times, super important that you understand your competitors. Behind the scenes, we're going to show you your two closest competitors. So this is real data from my hospital down in Georgia. Biopsy of the large intestine using a colonoscope, $9,312 is their average gross charge. The hospital in the same town, $7,554. The hospital about 25 miles away, $6,500. So if a patient is shopping, they're going to look at this and say, wow, I can drive 30 minutes and save $2,800. So that's just how we believe that over the long term, these service package benchmarks are going to help you understand potential competitive threats. Everything, like I said, is editable. You can click on any line in our tool. On the right-hand side, you will have the edit window. You can tab through all the fields. You can change any data. You can do multiple edits. If you highlight more than one thing, you can turn a lot of stuff off or on. Again, you can write filters to your heart's content and very quickly do spot checks around this data to make sure that everything is displaying the way you want before you push that publish button. Data requirements, a year's worth of claims data, a year's worth of remit data. As I mentioned, we built 3,500 service packages. We do need to validate those service packages with your claims data. Those service packages have been built with CMS data, but CMS doesn't have a lot of C-sections or labor and delivery. So there are some areas where we still need your data to build out some service packages that doesn't live in the Medicare data. We need 835 data, contract modeling data. If you have it and feel good about it, you would need to provide it to us in an Excel spreadsheet in a fairly simplistic format. We need your charge master and fee schedule for each hospital. We definitely need revenue and usage because, again, we believe that publishing onesie-twosies does not make sense, especially around service packages where there's a lot of drugs and supplies going on. If you have employed physicians and you're billing under the same tax ID number, it is a requirement to show those professional charges. We would show those on a separate line item. We would not mesh that data in with the hospital facility charges because your hospital competitor down the street may not have employed physicians. So we don't want to get into a situation with an apples and oranges comparison. So if you feel the need to publish professional charges, it would be published as a separate line item in those service package groups. I bring this to everybody's attention. This is the final rule that was published just a month or so ago, and Medicare wasted no time taking advantage of this new data that you're spinning up. So on the Medicare cost report, for cost reports filed after January 1, you have to put the median payer-specific negotiated charge, again, that fancy terminology that CMS came up with. So the median specific negotiated charge for your Medicare Advantage plans. That has to go on your cost report after January 1st. So they said that that data will be used in about 2024 to affect reimbursement. Right now, they just want to gather that data starting January 1st. All right, one last thing, I want to just show you the process for selecting all services. Everybody says, well, how do you select the services? What makes sense? And so I just want to go through this process with you. Again, we only have 45 days to accomplish this. So everything I can teach you about what we've done with our methodologies and processes will hopefully help you in the next 45 days. So this is a charge master. We've brought the charge master in. We've brought it in with revenue and usage data. We can see there's 7,800 line items. We can see on the right-hand side, I've got a reference to some pretty small usage. So the first thing I believe we should do is filter by usage and get rid of anything that is 10 or under. If we do that, our charge master drops to 4,390 line items. We already have our charge master online. The whole and complete charge master's out there with all the 252s, the 272s, any of those revenue codes that don't have HCPCS codes. We don't negotiate with payers for suture kits or needles. So we believe that we should filter out anything that doesn't have a HCPCS code from the charge master. So when we do that, it drops us to 2575. And now we look at, we have duplication in our charge master. We have a lot of line items that have C code 1713 potentially, or some of the other supplies and drugs that carry a HCPCS code. So we need to again, display one code. It's not patient friendly to show 3, 4, 5, 6 different codes with different technical descriptions. So we want to limit the number of codes by pivoting on the HCPCS code. We can see a third of the way down, there's 3 instances of CPT code 10060. We have 3 different amounts, probably because one is performed in the emergency room, one is performed maybe in a clinic or a procedure room. So we want to squash those into a single line item. You can see on the right-hand side, we would recommend using one code with $378 as the average price that a patient would pay. However, we now need to look at what happens when I send in 10060 on claims data. So we now lay those charge master line items next to the claims data, and you can see the very second line item is my incision and drainage of an abscess code, 10060. We have the CDM price, which was one of the highest prices, the 420. I can see that I used or did 25 of them just on Medicare patients, and the price came out as an average of $557. Well, that's what goes to the payers. So do we use the CDM price, or is the claim ultimately our guiding light with regards to this particular CPT code? And we believe it's the claim. You can see that there's probably some drugs and supplies. There's a suture kit, a scalpel involved, or a needle involved in that particular procedure. So there's about $130 of supplies. So this actually for us becomes a small service package rather than showing it as an individual line item from the CDM. So that's the mechanisms that we go through using claims data and CDM data to determine what is the all services display look like, which ones are individual items and which ones are service packages with some drugs and supplies involved. I'm sure you've all studied the final rule. You formed a transparency committee. You're looking at your charge master and your negotiated rates. You need to look at benchmarking data and see how your rates compare to your neighbors. We do that in our charge master tool. We need to determine which items are shoppable. Typically, it's the items that patients are calling and scheduling, or they're calling and asking for estimates on. You need to develop policies and processes. There will be patients that come into your business office with a screenshot of your data and having questions, so you definitely need to build out scripts. For all of you that are doing estimates at this point, obviously, you probably have already crossed some of those bridges. And with that, Tori, any questions come in?
Hey, Carrie. Yeah, so there was one question that came in early on, just asking if you could show the slide with penalties on it.
Yeah, absolutely. So I'm not sure if it's this one, which is $300 per day for every facility. So if you have 10 hospitals in your facility, it's more like $3,000 a day. Or if they were talking about this screen that talks about some of the things that CMS has said for non-compliance with regards to the corrective action plan, publicizing, potentially publicizing the hospitals that failed to comply. And then definitely there will be a written notice prior to anything else taking place.
Okay, perfect. Thank you. And then the other question that we had come in was, could you please define employed physicians? Is there specific criteria?
In the regulation, it says employed physicians or other providers like PAs. A lot of the hospitals we've talked with do believe the interpretation is they're billing under the same tax ID number. And many hospitals have formed a separate tax ID number and have separate billing for that tax ID number. So many hospitals are choosing not to show the physician, but it's really an interpretation that your chief legal officer or compliance officer has to make. The one thing that gets tough if you're not billing under the same tax ID number is 835s coming in and trying to size up those 835s with the facility data and making sure that we've kind of aligned those different claims. So that makes it a little bit tough when we don't see those things coming in on the same 835s.
And then another question just came in. The de-identified maximum and minimum are the average of the allowed payment on the 835. That is a question, not a statement. Should that data include the government payers in the average?
No, it should not include any government payers that are, as I said, off the table. So Medicare, traditional Medicare, Medicaid, CHAMPAs, all of those already pre-negotiated government payers and plans and fee schedules should not be used. The de-identified minimum is the minimum for any given payer. The maximum is the maximum for any given payer outside of those government plans. And then we display the average allowed amount for a particular plan. So it's the de-identified minimum is truly the minimum we see, the maximum we see. And then for the payer, it's an average allowed amount across all that payer's claims.
Okay, and then one more question on a similar thread. You've recommended using 835 reimbursement, but that would be historical. How do you recommend showing current allowed amounts, either for contract charges or updated prices for a percentage of billed?
Yeah, so Medicare says that they only want this data displayed once a year. And there is references in the final rule to historic reimbursement data. We do not know how to build service packages, right? Because service packages, I think, is the harder part. Once you build a service package, you kind of have to do that with historic claims data. if you've had new negotiations with payers, and we've run into clients that have done new fee schedules or new payer negotiations. So one is we can do the Excel spreadsheet and try to do updates to those. Again, we need simple spreadsheets using our identified packages. Another way one of our hospitals has decided to do it is for those payers that have new contracts after October 1st, they're going to have us respin the data in March and update everything in March. So they have 6 months worth of historic data under those new contracts. So even though CMS says that they only need it done once a year, we, in our contracts with our clients, are allowing 2 spins of the data. So we're going to do it twice. So for hospitals that have a year end in June 30 and they want to update in July because they know they've updated their prices. So that's the 2 mechanisms that we're giving to clients, is the spinning of the data more than once so that you can update those new contracts, or update because you've had major changes in your prices because of your year end and just typical charge master increases.
Great. And then the last question we've got here right now is, does the minimum and maximum include Medicare Advantage plan prices?
Yes, it does, and it has to. So that's the one thing that I've noticed with the data. And like I said, we've gone through over 6 million claims at this point. But what's really interesting is those minimum maximums, you're always running into those Medicare Advantage plans and the managed Medicaid plans, which are also required as being your minimums. So I hope that other payers aren't going to start negotiating, understanding those negotiated Medicare and Medicare Advantage plans.
Great. Well, that wraps up all of the questions that we have in the window here. So if there are any other questions, please feel free to type them in right now. But otherwise, I will get started on just wrapping things up here. So you still have a few more seconds. But thank you, everyone who was able to join us today. Hope that it was enjoyable and informative. And as I mentioned earlier, we'll be posting the recording of the presentation on our site, and we'll be emailing that link to all of the attendees from today's event. If you'd like any more information on anything you saw or heard Carrie talking about today, please reach out to your Vitalware client success executive for those clients, or for those of you who are not clients currently, you can schedule a demo on our website or chat with us at vitalware.com. So that concludes today's event. Thank you all for joining.
Thanks, everyone.